Hello, and welcome to this presentation by the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled Managing Emergency Department Headache Patients, Life-Threatening Headaches and COVID-19 Implications. My name is Edward Sloan. I'm currently Medical Director of the Physician Assistant Studies Program at Dominican University, and I have been an attending physician in emergency medicine at Carle Foundation Hospital. I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. The content for this lecture comes in large part from the monograph titled Evaluation and Management of Life-Threatening Headaches in the Emergency Department by Dr. Zoda et al. It was published in Emergency Medicine Practice by EB Medicine, February 2019. Please refer to the complete video and audio content for this educational lecture, as well as other individual parts of this lecture via links found at FERNE.org. You may also refer to the initial podcast and the CME option on the EB Medicine website at ebmedicine.net and specifically at the link listed below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. When considering patients with acute headache, we need to consider three involved structures: the CNS tissue itself, including the brain and spinal cord, the blood vessels, and the meninges. And then we need to consider that there are primary and secondary headaches. When considering headache etiology and diagnoses, it's sometimes first helpful to look at the Merriam-Webster definition of headache, which is simply a pain in the head. When you consider headache, 90% are primary etiologies that originate in the brain, such as cluster headache, migraine headache, or muscle tension headache. 10% occur with secondary causes, such as when a patient has a headache related to sinusitis, pharyngitis, vomiting, or dehydration. But there are also other secondary causes that include life-threatening secondary diagnoses. What are those secondary diagnoses that are life-threatening? They include subarachnoid hemorrhage, carotid and vertebral artery dissection or cervical artery dissection, central venous thrombosis, idiopathic intracranial hypertension, giant cell arteritis, posterior reversible encephalopathy, and meningitis and encephalitis. Additional secondary headache diagnoses include acute angle closure glaucoma, pregnancy-induced hypertension, carbon monoxide poisoning, and other head and neck infections, including sinusitis, pharyngitis, and lymphadenitis, which we'll address. The headache history. Our headache history should follow the OPQRSTU format. O, onset. Is it a sudden onset? P, provocative and palliative. Is it exertional in any way, such as with lifting weights or exertion? Q, quality. Is it sharp or overwhelming in some way, or is it a dull headache? R, radiation. Does it cause pain in the neck? Severity. Is it severe, or is it the worst headache ever experienced? Temporal. Is it constant or changing? And U for under care. Is the patient under care by a clinician for these headaches, and are there specific headache medications or other medications that might be impacting this? Headache-associated items. Are there infection symptoms in the head and neck? Is there dehydration caused by nausea, vomiting, heat, or poor PO intake? Are there stroke symptoms? Are there cardiovascular symptoms such as near syncope or chest pain? Is there dizziness associated with the headache? Has there been some remote trauma? And is there a specific headache history? What are our headache historical red flags? The historical red flags really include: is it a sudden severe onset with severity that occurs within minutes of the onset of the headache, such as being hit by a baseball bat in the head? Is it new age onset, greater than age 50? Is there significant neck pain? This is significant. Is there a malignancy history? Is the patient immunocompromised? Has there been an episode of syncope or trauma? And is the patient pregnant or postpartum? The headache physical exam. The general physical exam looks at vital signs. Is there fever, abnormal vital signs? Is the patient hypertensive? Is there apparent Cushing's response? Is the patient well appearing? Is there altered mental status, dehydration? Is there any evidence of pain or respiratory distress? Is there rash or any skin changes? Are there petechiae? Any evidence of dysrhythmias on the monitor or on cardiac exam? And is there any evidence of chest, GI, or GU infections? The head and neck physical exam is important in patients with headaches. Why? There can be sinus tenderness or temporal artery tenderness. There can be tympanic membrane or ear canal infection or abnormalities. There can be evidence of pharyngitis or retropharyngeal abscess, which can cause headache. There can be evidence of dental abscess. There can be nasal polyps or any green discharge, which would suggest infection. There can be neck swelling or tenderness or bruise. And most importantly, there can be evidence of meningismus, where there's specific pain in the neck with movement. The eye exam in a headache patient is also important. You want to know if the patient has adequate visual acuity. Can they count fingers at the bedside? Is there evidence of any vision loss or peripheral vision loss in one or both eyes? Is there a visual field abnormality? Is there a field cut, or is there an evidence of tunnel vision? Is there diplopia? And this diplopia can either be vertical, where one object is on top of the other, or horizontal, where the two objects appear to be side by side. Are the pupils equally round and reactive? Might there be a Marcus gun pupil? Are the extraocular muscles intact? We want to know specifically, are cranial nerves 3, 4, and 6 working adequately, or are there deficits? Lastly, the presence of a lid lag could suggest a cranial nerve 3 palsy. Then you want to look at the fundus of the eye to make sure that the discs appear sharp, that there's no evidence of papilledema and or hemorrhage or poor vascular supply. The headache neurological exam. You can use the AVPU system: alert, responds to verbal, responds to painful, or unresponsive. And you want to just generally comment on their mental status. Speech. Is there receptive or expressive aphasia? Is there dysarthria, difficulty in being able to speak? What is the motor functioning of the face and extremities? Is it normal? Is there truncal ataxia, where a patient can't sit up straight in a cart without holding on? Is the Romberg positive? Is the gait normal? Every patient needs to be discharged after you've proven that they can adequately ambulate, if they were able to ambulate before the onset of this headache. You'd like to know about coordination, such as finger to nose or heel to shin testing, and check for any abnormal reflexes. And lastly, you want to do some brief neuropsychiatric assessment to make sure that there's not some overlying psychiatric problem influencing the occurrence of a headache. What are the headache physical exam red flags? The red flags include an altered level of consciousness, such as a poorly responsive patient, presence of a seizure, fever, meningismus, where the neck appears stiff or the patient can't move their neck without pain, the presence of visual acuity changes and or cranial nerve abnormalities are clear red flags, as is a focal neurological deficit or acute psychosis. The occurrence of acute psychosis could suggest encephalitis, which may result in acute psychotic episode. Headache laboratory testing. Laboratory testing should include a glucose to make sure that alteration in mental status is not due to hypo or hyperglycemia. Surely a pregnancy test will help in the setting of presumed or suspected pregnancy-induced hypertension. You can get basic labs including a CMP, CBC, and UA, looking for abnormalities in liver functions, for example, or creatinine or dehydration on a urine sample. Also, you're looking for signs of infection. You can do an ESR and CRP, markers for inflammation, but please note that these have limited sensitivity in the setting of giant cell arteritis. A venous carbon monoxide level will be helpful when you have multiple people who have a headache in one setting, such that CO poisoning might be suspected. And lastly, you might do a D-dimer. This will exclude a cerebral venous thrombus, but only in low-risk patients. This D-dimer is not helpful in patients who are thought to be high or moderate risk following your initial assessment. Lumbar puncture. The question often comes up whether or not a CT should be performed prior to lumbar puncture. I would generally recommend that this be the case, as it is possible as you draw off fluid that herniation can take place, and a non-contrast CT will give you any indication of increased intracranial pressure prior to performing the lumbar puncture. If you wish to obtain the opening pressure, you should have the patient in the left lateral position so that if they're not upright, it won't influence the occurrence of an elevated opening pressure. If you don't check the opening pressure with a manometer, you can always just assess it as if to say there are a few drops coming out slowly, which suggests no increased ICP. Or if the fluid's coming out rapidly, you might put the stylet back in and actually formally check opening pressure, because if the fluid's coming out rapidly, that would suggest possible increased intracranial pressure. When you do the LP, you want to obtain the smallest amount of fluid, less than a cc as possible per tube. And when doing the lumbar puncture, you can use 4 tubes. Tube 1, hematology for cell count and differential. Tube 2 for chemistry, looking at glucose and protein. Tube 3, microbiology, gram stain, culture, viral testing, and fungal testing. And Tube 4, a repeat hematology tube for cell count and differential. Now, what about headache neuroimaging? The most commonly used first neuroimage test is a non-contrast head CT in the emergency department. We understand that this test is relatively low yield, that in most all settings, the yield for a positive finding is less than 10%. However, the presence of a negative non-contrast CT has a high clinical utility. It's usually accurate and allows the patient to be dispositioned home once you know that there isn't some space-occupying lesion or other problem. So it is the initial test of choice in all AD patients that require neuroimaging in general, knowing that it's useful in excluding subarachnoid hemorrhage, other types of hemorrhage, abscess, space-occupying lesion, edema, mass effect, and/or midline shift. Now, in headache, there are other tests that you need to consider. You need to consider whether or not a CTA or CTP should be done for ischemic stroke, CTA for subarachnoid hemorrhage, which excludes aneurysm, MR venogram for CV thrombosis, an MRI for vasogenic edema in PRESS, which we'll talk about, and CTA and/or MRA of the head and neck if dissection is suspected. When considering the diagnosis and treatment of emergency department headache patients, especially in the setting of this current COVID-19 pandemic, the following can be concluded. Emergency department headache patients who present with potential life threats can be identified. In order to do so, a systematic evaluation is critical, and the electronic medical record can help with this process. Most importantly, subarachnoid hemorrhage can be excluded in patients who present with sudden severe headache, given our current diagnostic capabilities. Also to be noted, head and neck infection, CNS infection, and CNS thrombosis must be considered if subarachnoid hemorrhage is excluded as the likely etiology for patients with potentially life-threatening headaches in the emergency department. During the time of this current COVID-19 pandemic, it is possible that common primary etiologies of headache, such as muscle tension headache, migraine, or even headache related to dehydration, can commonly be seen in emergency department patients. However, when considering patients with potentially life-threatening headache in the emergency department. At this time, it is worthwhile to always consider COVID-19 as a potential etiology of these life-threatening headaches. During the time of this COVID-19 pandemic, besides specifically testing for the COVID-19 virus, there's no need to specifically alter our approach to diagnosing and treating patients in the emergency department with life-threatening headaches. If you have any specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you also to go to the fern.org website for more content related to this educational program, as well as other content related to the care of patients who present to the emergency department with life-threatening illness and injury related to neurological emergencies. Thank you.